So first of all, we are going to talk about the physiology of the pulpal tissue, and we need to ask ourselves this question: why is it difficult to anesthetize an inflamed pulp? When we look deeper inside the pulpal tissue at the nociceptors, we need to know what happens exactly to the nerve fibers. First of all, normally a stimulus gets over the normal threshold, and once the threshold have been reached, an action potential can be charged to send a signal to the brain of the pain stimulus. But when we have an apprehensive patient with a lower pain threshold, the stimulus will be the same, but the difference will be that the excitability threshold of the inflamed nerves will be lower. The decreased excitability thresholds of the inflamed nerves will allow the stimulus to pass much easier, so triggering a faster action potential than the normal situation. The other thing that will happen is the sodium channels will be resistant to the anesthetic solution, and the inflammation and bacterial insult can lead to sprouting of nerve fibers, and the increase of neuropeptides and inflammatory mediators can also lead to excitability of the nociceptors. So in a clinical scenario, when we have a decrease of the firing threshold, this will contribute to the sensation of pain, which is allodynia. And simply, allodynia is the previously non-noxious stimuli that contribute to the sensation of pain. And after the discharges of the action potential, we could have a greater increase in the perceived intensity of pain, which is known as the hyperalgesia, which is simply as the noxious stimuli that may produce an even greater increase in the perceived intensity of pain. So in the clinic, when we want to test for the symptomatic irreversible pulpitis, usually the patient have a spontaneous pain, and when the patient have a reduced pain threshold, it could be tested by either a percussion test or palpation test, or the patient could be having a throbbing pain. Usually, like for example for the percussion test, when the patient bites on his teeth, there is no pain. But when there is a reduced pain threshold, the patient could have a severe pain by biting or simply by the percussion. And when there is an increased response to a painful stimuli, we could do a pulpal test. For example, in the thermal test, usually in a normal tooth, the patient would experience a short duration of pain, but in an inflamed pulp, the pain will be more severe and takes a longer duration. So what is the chief complaint of the patient? First of all, he would have a spontaneous pain that seemed to be unprovoked. And when the patient have a reduced pain threshold, he could have pain while drinking cold beverages, or he could say, it now hurts when I bite on this tooth. And when there is a hyperalgesia, usually the patient have an increased response to a painful stimuli. So when we put all of these factors together, this will explain why local anesthesia is not always effective when patients are in pain. So there is no miracle solution or a nerve block injection technique that will guarantee 100% effective pulpal anesthesia in patients specifically with symptomatic irreversible pulpitis. So for most patients, the only addition of supplemental techniques would produce an effective pain relief. Usually the success rate of an inferior alveolar nerve block, the range is around 25 to 39% when there is no or mild pain on endodontic axis. So to increase the chance of having a more successful anesthesia, we could supplement with 4% articaine given as a mandibular infiltration. But to be clear, articaine is not superior to lidocaine when given as a block. So what the studies say in using articaine as a mandibular infiltration, it could increase the chance of a successful anesthesia to a range around 42 to 48% in the molar area and up to 73% in the premolar area. So how about giving 2 nerve blocks? It could help decrease the chance of missing a nerve block, but the incidence of missing a nerve block is 6% or less. So it's not necessary to give 2 blocks. Actually, the success of giving 2 nerve blocks is because you are giving a more appropriate time for the first injection to work. We should know that the onset of pulpal anesthesia after a nerve block ranges between 5 to 19 minutes and could be as late as 30 minutes post-injection. Another way, we could give a pre-injection medication. For example, we could use ibuprofen to reduce the levels of inflammatory mediators before the anesthesia is given. So studies have proven that preoperative ibuprofen or a combination of ibuprofen with acetaminophen could be used for the clinical condition of symptomatic irreversible pulpitis. But again, we should always use another supplemental anesthetic technique. How about giving another injection technique? For example, doing a different type of block injection. In this case, we could do, for example, Gauge technique. But the studies have proven that there is no difference, or the success rate are similar between the traditional nerve block and the Gauge technique. But it is always recommended to learn the Gauge block for specific types of cases. Now to the most predictable way to achieve pulpal anesthesia, which is the intraosseous injection. It could be successful up to 90% of the cases. Another way to supplement is by using the intraligamentary injection, which could increase the chance of having a much higher success rate, up to 63 to 74%, and by re-injecting it could raise the level up to 92 to 96%. But even after using all of the techniques that we have just explained and talked about, there is still 5 to 10% of patients that do not get anesthetized. So the last thing to do is using the intrapulpal injection. But the main disadvantage of this type of injection is that it's very painful, and that's why it's only should be recommended to be used after doing all other types of supplemental techniques. And the main point of this type of technique is that we have a back pressure while injecting the local anesthesia. So the conclusion is that we don't have a single drug or solution or technique that will allow dentists to treat every patient with symptomatic irreversible pulpitis. So we should always start with an F block and supplement it with other types of techniques and adjuncts that could be used. For example, prescribing an NSAID before the appointment to increase the success rate of pulpal anesthesia. And the last thing to always remember is to give the anesthesia more time to work. It could be up to 30 minutes in some studies.